Excellent. And it has begun. And for some reason, I'm getting a transcript. Oh, well, I don't think I want to see that. Well, good afternoon, everybody, and thank you so much for taking the time to join us for this afternoon's Talking Systems conversation about organisations as a living system. And I'm delighted that we have today Manoj Pawar, who is a physician working in the United States. So we were discussing for Manoj, it's 9 o'clock in the morning. So for us, it's towards the end of the day, and for Manoj, it's the start of the day. So it'll be sparky and fresh, unlike me, possibly. So it's lovely to welcome you to this meeting, Manoj, and thank you for taking time to talk to us about your experiences as a clinical leader, and particularly your thinking about systems. Now, Manoj is a senior physician executive. He's over 20 years healthcare and executive leadership experience. He currently works for Mutual of Omaha as the chief medical officer, and that's the second largest Medicare supplement provider in the NHS. And his work there involves trying to improve health outcomes and affordability, which seems to be the challenge for every health system in the world, to be honest, whilst providing clinical leadership for a national prescription drug plan. And I spotted Manoj because he'd written what I took to be a fascinating short article in something called The Systems Thinker, where he talked about thinking about our organisations as living organisms. So that's why I was very keen to see whether he'd come and talk with us today, and he agreed to do that. The way these sessions run, I'm going to give Manoj 15 minutes to do a kind of introductory piece about his work, his experience, some of his thoughts about some of the topics we'll be looking at. Then we'll move into a conversational piece where for about 30 minutes I'll use the questions that we got from people before the meeting. But of course you can use the chat box. So if suddenly you think, oh, I really want to ask this question, then just put it in the chat box and it will be a test of my competence to see whether I can maintain a conversation with Manoj while also checking the chat box. So that will be the test for me over the next just less than 60 minutes. So on that basis, I'm going to stop talking because we've got somebody more interesting to talk at this point, and I will hand over to Manoj.
Thanks, Mark. I really appreciated it when you reached out to me, and it was it's my pleasure to join everybody today. I want to just say that this is a couple things. One is I know it's late in the day, so I want to try and I feel like this is a small enough group that if we have chat, questions back and forth, I think that we can still accomplish that with 20-something people on a virtual meeting. I know it can be a little bit challenging at times, but yeah, I just, as Mark mentioned, I'm a physician in the United States. I continue to practice a little bit, and I also continue to maintain a leadership development and consulting practice to a small degree, although my main role right now is for a large health system in the United States. And I want to give you just a couple of minutes, just so you know, it gives you a little bit of a lens into my way of thinking about some of the problems that we face and why I do the work that I do. And I think it'll be relevant in terms of our discussion later on. So I started my practice in the mid-90s, and as part of a group that was going through some really difficult times. I mean, we were losing a lot of money, we were constrained on resources. We were actually faced with the dilemma of having to turn around. We were given an ultimatum by our board, had to turn this group around within 3 years, or we would be shut down. And so, this really called the question of, who wanted to, what do we want to do about this? And while there were a lot of people that just left and found other places to work and practice, there was a core group of us that really felt strongly that we have something meaningful here that's worth saving and that we could rally around. And it was during that time that I really felt that, what drew me to this is an opportunity to kind of support people that care about delivering better and better care and improving the experience for the patients that we serve. But I also felt that there were a lot of clinicians and staff on the front lines that were doing really good work where the system just wasn't set up to allow them to do that. And so I guess you could say that this drive to improve things and to make things better for patients as well as for caregivers was something that's really stuck with me throughout my career. We did turn around that group, and in the process, it was an exercise in building culture. What we were left with, sometimes these sorts of crises lead you to question sort of the, why do we exist? What's important to us? And then as you start to stabilize and regrow, how do we know what we're about when we add people to the group and we start to regrow again? What is it that indicates that this is a good fit for folks, or how do we retain sort of that sense of purpose as we continue to grow? So fast forward, that was a formative experience for me, and during that time, I became the CEO of that group, and really wanted to spend some time understanding a lot about the cultural and the leadership development needs that we had in that moment in time. And when we, as a result of that, I had a mentor that was really involved in the OD space primarily, but more specifically in the systems thinking world, who pulled me into a lot of this work that really got me interested in developing a consulting and coaching practice and doing all of those sorts of things. But one of the things that I like is that the principles are applicable along the way, no matter what the scenario. So prior to my role at Mutual of Omaha, I was the chief medical officer for a national health system in the U.S., about 103 hospitals, and in 19 of the United States. So the context can change, but the principles still apply. And what I find a lot is that it's difficult for people. So it's this transition from from theoretical to daily practice, and making it relevant. So there may be some interesting ideas or concepts that we bring from in terms of leadership development interventions or organizational dynamics work, but they're too abstract or not necessarily practical for people on the front lines to truly understand. So when you're trying to engage clinicians in particular whose time is limited, we a lot of times bump into these roadblocks. But that's why I do what I do. I want to improve care. I really want to apply the things that I've been working on over the years. And I think, to Mark's point, the paper that he brought up, it's been quite a while. It's been over. I had to look back and remember what I had written. Actually, they're still true. It was a paper that I can share if you haven't already, Mark. I mean, I can put it in the chat, but it really says, hey, these are concepts and systems thinking that are really that are ingrained in the clinical development, right? So if you're a physician or a nurse, these are things in the human physiology that you're going to be really familiar with, and it attempts to take that and translate it to say, hey, how we talk about that endocrine feedback loop that with the pituitary gland and the thyroid. There's a similar sort of thing that happens in organizations, and that's what we're trying to build and to create organizations that are more resilient. So that's my story in terms of where I'm at, and I'm eager. In prepping for this, while we have different systems that we work in, I've also got a Canadian perspective from where I trained, but primarily my career has been in the United States. There are a lot of similarities in terms of the everyday happenings of trying to engage physicians, nurses, and other clinical leaders to try and improve the system, and running into barriers along the way. So that's where. So Mark, I think I'd love to I made a decision not to prepare any slides because I really think this is better off as a conversation, and we can share some information after the fact if that works.
That's fabulous. Thank you, Manoj. So I was listening to you talk there about that kind of bridging effect, which strikes me as really critical when you're thinking about supporting people in terms of their systems thinking. So one of the challenges I've had back on many occasions is if I start to talk about systems, it does feel quite abstracted. And one of the observations somebody made to me a while back was if you start to talk in that way, and particularly depending on your audience, what you're doing is flooding that space with a sense of anxiety, because you're using terminology that may not land brilliantly well with people. It can seem very arcane in that sense. So I wondered whether you got any practical observations about, so you've talked about in the article, but whether you've got any practical experiences around that bridging, and particularly bridging into talking to clinical leaders and helping them to think systemically.
Yeah, I think it's important to also be really particular about the context. I know we always like to talk about how, in models of adult learning, it's important to make things real. I mean, they have to be tangible, concrete, and addressing a problem that's relevant at the moment. And so I think a lot of times when we sort of, my experience in a lot of times we put these programs together and we talk about these things hypothetically, but there's no direct application. I personally I try to avoid the use of systems thinking language in the abstract, but really try to understand, well, what are the problems that we're trying to deal with, So, I think one of the things that comes up a lot is understanding, well, why do we even care? Why, and this is, it sounds silly, but if you're imagining a conversation with a busy surgeon and you're trying to improve, I can use the example of inventory management in the operating room and trying to figure out what supplies are being stocked, which brands, what's being contracted, OR scheduling times. Well, the surgeon, you need a physician. We want physician leaders to be involved in that, but we're trying to have the conversation about trying to think systemically. Why? Why should that surgeon care about this? And so I think a lot of times it's important to step back. I think we jump into, I think conversations looking at systems and diving right in are one of the, I think it's important to take a few steps back and really start to have the conversation about a shared sense of purpose. And we a lot of times in healthcare don't do that. It's a lot of times we want to get something done. We want to reduce expenditures. We want to reduce wait times. We want to improve operating room turnover time. But we're not necessarily willing to step back and do the hard work of really setting the context and engaging in a conversation about developing shared purpose. Does that make sense?
Yeah, I think it does. As you were speaking, I was thinking there's a really strong reminder in there about how leadership in a really traditional way is very action oriented. So, you hear in management settings so many times, that's enough talk, let's act. And it's all about the act. But I think the way you were talking there was about giving a bit more space, particularly around the issue of leadership in a systems context, to define what it is you're trying to do and why you want to do it and how you might do it. So I wondered what your thoughts were about giving space and time to people working in extremely busy circumstances and working at a high pace and in high reliability organizations, how we might think about supporting people with space and time to do that essential pre-work before we get to thinking about what experiments we might want to do or what tests we might want to undertake. What would your views be on that?
I think there's probably three things that come to mind from my experience that are useful to address. One of these front and center is really we're trying to do a lot of different things right now in our pandemic response. There isn't slack or capacity in the system a lot of times. We're trying to, the joke among clinicians is, yeah, I've got another wellness program or resilience program that I have to attend. And it's not really a joke. I think what they're telling you is these things are not helpful for me in this moment. It's sort of trying to, I want to do something as a health system leader, so I'm going to do this for you. What they need is resources and time and space, and understanding that may not always be possible. What I find is that the next best thing, or probably maybe even a better thing, is to try and think about things in terms of these cycles of intense activity followed by periods of rest and resilience and reflection. So, you have to do that. It's the same thing as in war, in the battlefield. When people are, it's not like I'm done and I can just kind of relax. It's, you have to develop this pattern of intense activity followed by periods of resilience. So what do you do about that? This is tough because it comes down to economics on some level. We have to create space in the schedule. If we really value clinical leadership and want to meaningfully engage in that, if we really believe that that is necessary for a high functioning health system, we have to value that and provide the time and space for that to happen. I don't know the number of times I'm working with a hospitalist team right now where I'm coaching their leader. They manage a team of probably 120 hospital-based physicians and physician extenders across their regional system. And they have maybe 0.25 FTE dedicated to managing 120 providers. How is that possibly going to work? Because the rest of their time is related to a clinical focus. So I think one thing that we can do to provide time and space is to really advocate, to say, this is important, we're going to carve out this time. And if it means also providing some support and backfilling the clinical aspects of that, we're going to do that. Second thing is also understanding that while we may do a lot of things in the executive or the administrative conference rooms, and so we may have already processed all of this. We may have had the time to reflect, digest, debate, discuss everything. We get to a point. They've not. And one of the most important things to realize is if the way to disengage others that have not been that part of that process, to say, look, we've already, or maybe not say it explicitly, but to think, we've already figured this out. We just need you to sign off on it. Well, I think that sends a very clear message that, doesn't value the clinical workforce as a valued partner in the process. So that's the second thing. I think the third thing is that I feel is important is to understand and to challenge the folks doing the work. So let's say we have a particular initiative. We want to increase. We need to figure out what we're going to do to increase, throughput or capacity in a hospital system. We need to really encourage the non-clinical folks, as well as the clinical folks, to really take time to fully understand the system or the different elements of that, because I like to say seeing the system is something where we tend to be limited. We see what we want to see from where we sit, and that's human nature, pushing us and our teams to expand that by talking to other people and engaging in dialogue to expand what that system is, we may use the term stakeholders. understanding and gleaning stakeholder perspectives. That's a really important step, and that's a way to slow things down and to provide a little bit of space so that we challenge people doing the work and develop our teams to say, you can see more effectively. We can all see more effectively if we do this together. So those are the three things I think that are really, really valuable steps for teams.
That's fabulous. Thank you. I think that final challenge you talked about is a really big one, because it's that argument that you can't see the floor under your feet. We're all working in the system. We're part of the system, and it's quite difficult then to have a traditional leadership view, or a view that you can look at it, the system, and make sense of it as if you're not part of it. And I think the way you described that, kind of working to understand the system using dialogue to map it, seemed quite powerful. Was there anything else you could say about that kind of process of giving people space and time to think about what the system is that they might find themselves in? Because a lot of the time you're in the system and just running to keep up. So taking time to there's stuff about network mapping and things like that, but that never strikes me as terribly systematic or systemic. So I just wondered if you had any other observations about how that process might work in practice.
Yeah, I mean, I think one of the things that I found, I'll give you an example. So this was several years ago in a prior role where, I was brought in as the chief medical officer and the president for to build out a regional outpatient group, clinical network. The problem was is that there was a lot of disarray in the system overall. The traditional operating model prior to us getting there as an executive team was, the physicians would ask, for something, and the administrator's role was to typically say no. It was sort of this transactional, people had their archetypes they played out, and they were so accustomed to that. The other archetype that was present there was, I'll do something if you pay me to do it. And there were all sorts of backroom deals that were going on that nobody knew about. So what we did was start to talk to a lot of folks. I didn't have a lot of physician leaders available to me at that time, so you really didn't have this opportunity to take breathing room, develop people. You had to say, look, these are people that have some glimpse of capacity or some interest. Let's bring you together. I'll devote my time. I'll meet with you once a week, and we'll grow from there, right? We'll divvy up tasks and engagement activities. So these were the chief of staff and the assistant chief of staff, and let's have you're responsible for these service line leaders and you're responsible for these. Go out and talk to them. Let's find out what's on their mind and let's collect them together. We'll meet together on a weekly basis and we'll determine where we want to go. One of the outputs of that was getting back to your question about how do you practically get people to see the system, is to bring the components of that system in the room. So what you hear is, you know what, so-and-so did this, or you guys made this decision and you really left us out. Primary care has never been a valued part of this whole decision-making process. And all of your investments go towards the specialty practices, especially orthopedics, whatever, nursing is saying, well, the doctors don't, we've had all kinds of, unruly behavior in different parts of the system, and you're enabling that. So it's overwhelming, right? But you have to bring those perspectives together. So we had what we called big tent meetings. This is something that was it was a commitment. It was a leap of faith. People needed to agree to come together after hours or on a weekend. We agreed to pay them. It wasn't a lot of time, but it was important enough to kick this off, to sort of have facilitated sessions. Let's get all of sort of those folks in a room together, or representatives from each of those areas, with the commitment that they would also communicate and engage. They would be two-way conduits for this. Facilitated sessions to really understand, what's on your mind? Let's check in. Almost, and I don't want to use too much terminology here, but if you're familiar with the World Cafe concept, that was the basic construct, right? Powerful questions, really relaxed, cocktail environment. Let's rotate tables. Let's have people, connect with one another as human beings, and then move into this. And that's where we really started to capture the aha moments around. I had no idea that when we made these decisions, this affected you in this way. That was the first meeting, is uncovering that and getting people to see parts of the system. On an individual level, what I did personally was with my physician leadership team was start to build that out and bring other people in to say, you're doing, and people started to, the first two started to realize, oh, we've uncovered other people that could be allies on this journey. Let's bring them in and let's put them out there and start to challenge them. I mean, part of challenging them was discover the system, try to define that, and let's really come together weekly and understand what we learned, what we already know that's validated, and what didn't we know. So that was a big part of it. I think the other thing we had to learn about was, or that we emphasized, was don't go out with a checklist and say, I'm going to interrogate you. we had one person that we had a rounding program. It's important for leaders to round in different areas, and there were some leaders that really approached it as an interrogation, versus forget that. Let's just connect with people as human beings. I want you to find out who they are, what's important to them, and develop a human level of trust and relationship first before moving on. So that's big scale and then individual scale.
That's beautifully expressed. Thank you, Manoj. Emma, I can see you raise your hand. Can I invite you in?
Hi there. Yes, thank you, Manoj. And from what you're saying there, it's really interesting, because I was just thinking, in terms of my role as a patient and public voice partner, in terms of bringing people into the discussion and conversation in organisations, the feedback that we get a lot as patient and public voice partners is it just brings it to life, what we're trying to achieve, and making it more real, and real life experiences that are powerful and really hit home with people. And I think I don't know if you'd agree that it's quite important to involve people like patient and public voice partners in terms of patient-centered care as well, that we're trying to achieve, and person-centered care with carers and families, and just bringing that human, real element to it could be quite powerful as well. And I think that's the feedback we've been getting and being a part of programmes within NHS England. And in terms of bringing experiences and talking about your story and experiences, I think it kind of brings to light, this is what happens if the system isn't working efficiently. This is the consequence of it. And I think that's the powerful bit, because people can relate to that, and it's tangible and it's real. So I feel like that's definitely made a difference in terms of the programmes I've been working on, and that's the feedback that we've been getting. Have you found that as well?
Emma, you're so you're right. I'm glad you mentioned that, because the sort of the next phase of this particular example I mentioned was really, one of the questions. So let me step back. One of the things that we, in terms of, one of the initial intentions is to build a sense of shared purpose, right? Without shared purpose, it's very difficult to accomplish important things, and we are, a lot of times we forget that we actually have among all industries, we've got some very low-hanging fruit in terms of shared purpose. If you're in healthcare, there's something that you likely do because you want to help people, you want to help patients, right? So let's not squander that opportunity. I think the patient perspective, the human perspective, we use the same term, person-centered care, is extremely important, and that's what brings it to life. We debated it in that scenario. Do we bring do we invite patients in the system initially, or do we do it in the second round? We chose to do it in the second round, partly because there was enough conflict, and we wanted to really kind of emphasize that, coalesce the group, knead the dough a little bit before we brought them in. But that's critical. I mean, I think we, at all levels, bringing the patient perspective. We also made it a regular practice to bring these patient stories to the board and to hardwire that into regular meetings that we were having throughout the system on a regular basis. So,
and I think the other feedback we've been getting is that often, members of the public can bring really good ideas to things. So, finding those solutions as well to issues that have often been barriers for years. And then it's just like a bit of an aha moment of actually it's not that complicated. If you just change this bit, it makes all the difference. So yeah, I have found that being a part of programs and healthcare programs, bringing experiences and real stories has made a big difference. And I hope that they'll NHS England and health organisations will look to do that more in the future, I think, to support system change.
I think that's powerful observation, particularly in respect to what, Manoj, you said earlier about empowerment. And if you say to people, I'm going to empower you, but in actual fact you then set them up to say, I'm empowering you to agree with me, that's a terribly debilitating circumstance. And I think from a health system perspective, whether we're talking about working with the workforce or whether we're talking about engaging with service users, it's really important not to close off the fact that dialogue has to be authentic. And there is a lot of, from my perspective, work around staff engagement, staff involvement, staff empowerment, which is broadly speaking ideological rather than actual. It presents a picture of what leadership in organizations would like to think is happening, but it's not authentic in that respect. So I think there's really powerful theme there that you're exchanging around, which is that empowerment and hearing the voice, particularly of those, the sharp end of where we're delivering service, capturing that and understanding it and supporting that understanding and nudging it towards what would your fresh ideas be? What would your freshest thinking about this work be? That seems a very powerful approach as well. I'm going to go to Lisa because she's had her hand up very patiently. Lisa.
I'm trying to frame what I want to say as a question rather than as an observation, so forgive me if this comes out a little bit jumbled, Manoj. I work across the Cheshire Mersey healthcare system, which is the second biggest system in the UK, so it's very complex, lots of players on the pitch. And one of the things in OD we often get accused of is that we're a bit pink and fluffy. And I think that's because we try so hard to build consensus, to develop shared purpose, to work with all the players in the system, that actually getting to a decision and an output, an action and a result can take so long that people kind of get fed up of us. I don't know if there's any advice that you can give around that.
Yeah, I think a similar question I'm seeing in the chat along these lines, but you're right. I mean, I think it needs to be balanced, and you have to, so we don't always have well, yes, there can be frustration because people want to see something done. And at the same time, sometimes there's just not there's enough going on, and the speed of change and response is so rapid that it's really difficult to say we're going to take time out and take a day and have a series of retreats that are going to get us to go through a process to get there. And you can do that in parallel, but you have to, I think, what we were conscious about doing, and what I recommend to client organizations right now, is to also really pick out some very concrete, doable things. Like, there is low-hanging fruit. There's something that people can say, you know what, there's big things to conquer, but if we start with the biggest and most complicated thing before we get practice on the easier stuff, we're going to get stuck and we're going to spin, and people will get frustrated. So So being purposeful about eliciting small wins, number one, and being explicit about acknowledging what you just said is, it's frustrating for them, it's frustrating for us, if we're the ones facilitating the process. Let's see how we can do this and give people some metric, some visible progress over the course of time. So we, an example would be thinking about, there was one of the most difficult things we needed to tackle was compensation, and that gets physicians in particular pretty tense. And but that wasn't we wanted to get there, but in that particular example, we said, well, let's just tackle part of it, and let's agree that everybody that's part of this process will share back visibly with their part of the system what progress is being made. Did we want to tackle sepsis as a system overall first, or did we want to tackle hyperglycemic episodes in hospital? These are things where it's okay to let them actually decide and say, I think these would be the easier things to go forward first. That's one. The second is never underestimate, I think, personally, the ability of leaders to actually make a difference one-on-one or in small groups or in meetings. I think one of the frustrations I have is, let the OD team take care of it and I'll wash my hands of it. If you need me to kick it off, I'll show up at the meeting and I'll say my few words, but I'll do that and you run with it. I really don't think that's appropriate. I think that's a abdication of a leadership responsibility. There's got to be some proper engagement one-on-one in small groups and teams. And so I think there's a lot that can go there. So without getting into too much detail, coaching the executives that are most, or whether they're executives or whether they're particularly influential individuals is another important thing that can actually accelerate change.
I'm taken by Lisa's observation because I think it's a plight of people that work in transformational roles or OD type roles that in many instances we work in a context that isn't sympathetic to the work we're trying to do. So the corporate context, despite constantly calling upon OD to try and do things differently, is not a suitable seedbed for the work we would want to do. So the constant imperative around pace, can we get this done quickly? Can we stop talking? Are we too pink and fluffy? As soon as you said the phrase, Lisa, I was thinking about some work I'm currently doing in an integrated care network in London, where there was a kind of two clear perspectives as we had the conversation, one of which was, we need to have a conversation about this, which I thought, yes, you do. And the other of which was, we've had too many conversations and nothing ever happens. It's got to happen. So I think we're always working in a space that is difficult for the work we want to do. And that's not a terrible, helpful observation, but it is a real one. I think, Manoj, you were talking about that kind of getting down to a base level where you're looking for the spaces, the organizational spaces where you can make a difference in terms of doing things differently. Whereas quite a lot of the time, I think we all spend up at a slightly stratospheric level with grand plans around transformation and RAG-rated reports, when in actual fact, the work is down at that base level in terms of trying to chunk it up and try and make a bit more sense of it, and to then give license to people to work differently on the basis of their experience. And I think it's, in a systems context, particularly in the UK at the moment, there does strike me as a quite interesting tension between staff sometimes saying, I'm quite fearful about coming up with ideas because I don't know what I'm allowed to do and what I'm not allowed to do. and that partly reflects a quite strong tradition of command and control in the NHS, and equally senior leaders clearly carrying quite a lot of anxiety about, well, if I release this and allow people to do this, what am I left to do? Where are my red lines? So quite a lot of the work I'm doing present in that space is just trying to get those two bits to have a conversation about what scares you about coming up with fresh ideas, and where are you willing to go as a senior leader? I spot that Laura has a hand up, so can I call her in?
Hi. Yeah, it's been really interesting listening to this, and I was particularly struck when you were talking about the role of the executive team and where the executive sponsorship sits. And for me, so I was lead for health and wellbeing in London for the pandemic, and I noticed the sea change, and I've noticed it as a continuation, was for me when the finance director, when he was talking about recovery, spoke first about workforce. And I think that's what it is about getting a coherent narrative across the whole senior team, where they're using similar language that bisects each other's portfolio. So the finance director talking about workforce and health and well-being, because that then shows that it can be monetized in that respect, or it can be operationalized if it's the chief operational officer. So I think it's about actually creating a headspace for that leadership team, so they get how each of the portfolios have, like, it's like that team, good team working, the interdependencies of their portfolios. And actually, yeah, that for me was like, oh my God, we've landed this. We've landed health and wellbeing for workforce because the finance director for the NHS just spoke about it.
I think you're right, because I think, well, and it goes to getting back to the, pink and fluffy concept. I think relevance is really important, and that's what I think. I acknowledge I struggle with this sometimes too. I love the theory, and it's a conscious process for me to connect it to what's actually going on in a really meaningful way. But the example of sepsis, going along what Laura had mentioned, is sepsis was, we had a national sepsis initiative to improve outcomes, and this is a clinically driven initiative. There was a surviving sepsis campaign. A lot of things were lined up, but getting the other part, getting the CFO, getting the operators and the clinicians in the room together to really understand that from the different perspectives was really important, because they understood that, when you talk about improving sepsis care, a couple things happen. Costs go down because we standardize supplies. We also reduce the ICU length of stay and so on and so forth. And so they see it from both an operational and financial perspective. So then you start to get this alignment back and forth among these different parts of the team, and then they're able to have a little bit greater passion behind the initiative.
I really like Laura's observation in that respect, because I often say that when you think about corporate values, very often the values aren't there to bind people in the organisation together. They're there to bind the top team together, because they're often quite rugged individualists, and they're very often coming from very discrete places like finance and HR. And so I love the idea that if you've got the finance director talking about workforce, you've cracked it in some fashion. I think that's absolutely right, and it does represent, I think Laura used the phrase, a kind of sea change in that respect. I've got two quick questions from the chat box. I'm conscious of time, which is flying by, which is wonderful. But Hashum has asked a question about whether you had any observations about horizontal integration. So certainly the challenge in the UK presently, and it's often kind of constructed in a slightly mechanical way about how do we link health and social care. So I wonder whether you had any observation about horizontal integration. And Joe, you may have addressed this in some of the other answers, but was talking about whether you had any thoughts about the pace of systems changing and whether there was there may not be, I mean, thinking about systems, but whether there was some sense in which that pace might be intensified on the basis of your experience. So something about horizontal integration, something about pace, just two quick ones from the chat box.
Well, I'm glad you brought up the question about horizontal integration, because if we were in a room together and had a whiteboard, what I would do is, even looking at how we try to solve problems in healthcare, we think of, okay, here's the system, right? So there's different versions of this, but we talk about, well, here's this, there's the patient at the center, and we've got the hospital here and the clinics here and everything like that. When in fact, most people, another way of looking at this, I mean, is it's a really narcissistic way that we in healthcare look at ourselves. I mean, everything is part of the health system, right? In fact, there's if you look at society, community, people, health, hospitals, businesses, social organization, NGOs, social organizations, and other sorts of things that are out there. Those are all part of the system. We are one part of it. They are not part of our ecosystem. It's a much broader thing, and that's the way that I like to look at these things. The other piece of it is, I don't know. I mean, I think, unfortunately, the efforts to integrate need to be more purposeful, but it's really about expanding that. What do those different parts of the system do, and what are they working on? There are things that they do that could help us, and vice versa. We just don't know about that a lot of times, and we're so busy in our own worlds and our own objectives, our own metrics, that a lot of times we don't take time to look at those things. So I think it's essential to map the system out that way. And I think I know what I do as a leader for my team is to really encourage them to make connections with to challenge them to make other connections with maybe what's not traditional, and also to look outside of our organization. So let's look at the departments of public health. Right now, I'm working on a loneliness initiative in a number of states, a number of our markets. And, one of the challenges at that last mile, what are the non-health system related resources in those communities, and how do we get them plugged in? So.
Okay. Did you have any observations around pace as an issue?
So yeah, it goes back to what I was mentioning earlier, and I think couple things that I've found helpful are to ingrain the discovery process as part of the routine work of the organization. So if I'm an executive team, if I'm a middle management team, it's important to challenge folks just as a baby step. 1% improvement every week is perfectly fine. Let's have a conversation, meet people do the discovery with one-on-one conversations or with small groups, and bring things back to coalesce a lot of that. So I think that's part of it. The other part of it is also micro level, small wins or impacts. Okay. Being purposeful about that.
Okay. Emma, we're up against time, so if I can invite you in briefly with question or comment, and that will probably be our last contribution today.
Yeah, thank you. I just wanted to mention that, like, as an observation, as like a patient and from a patient care family perspective, one of my experiences was looking after my mum who was terminally ill with breast cancer, and that brought about quite a few issues within the system. And since then I've been keen to try and support in the developments and improvements in that area. And I think what I found along that journey is it's quite helpful, I'd imagine, for clinicians, and they said this to me, where if you look at what happened and then work backwards, so it's like, well, this happened in this situation. There's no blame towards one person, because at the end of the day, I would hate to point the finger at one person. It's a system failure. And work backwards and sort of think, well, actually, how did this come about in this situation and these things that she had an issue with, or this situation, and kind of work it that way, and then look at a broader picture of the organisations that could be involved to support that. I think sometimes when you see a real issue that's happened, or a challenge that's happened to a person, and then work backwards, it kind of it then opens your eyes to actually, oh yeah, we could do it this way, or if we'd done it this way. And there's not sort of that blame game of people feeling like they're fearful of owning up to that, because it's just a scenario. There's no names. It's just, this is a situation. How could we have done that better?
Yeah, I empathize. Yeah, having, my father was ill and passed away 3 years ago, and going through that, he was a surgeon. And going through this and being a patient, and I mean, I know how to navigate the system, and it was the most frustrating thing for me even then. And the way that, you know, people don't necessarily, I empathize, and I also think it's so important to be able to put that perspective into place without blame. I mean, there's a lot of things that kind of come out and say, well, it's no one person's fault. There's a systemic issue that we have to find, in which we have to find the leverage points.
Mm-hmm.
Yeah, I think that's absolutely true. Manoj, thank you so much for your time. That has been a fantastically stimulating hour for me, and I hope other people found it useful. I've sketched out a phrase here that you've just used about the narcissism of healthcare, which I think is a really nice way of putting how we can be quite insular and just looking at ourselves as the system instead of looking at it more broadly. And so in a brutal piece of marketing, I just mentioned to people on the call that we have an event on the 13th of October called In the Service of the Health of All, which is a systems meeting that is trying to challenge people to take the broadest possible systems context. So going beyond health, going beyond social care, going out into thinking about built environment, housing, education, all the other issues that we know play a vital part in terms of health outcomes. To look at that from a population health perspective and start to think about it in terms of health inequalities. And we've got a number of fantastic speakers on the day, but it just struck me as a fantastic bridge, which is where we came in from the conversation we've had today to what I think promises to be a really rich conversation about, can we take systems thinking even further in terms of, it's not just about the networking, which is important, it's about thinking completely differently and really creatively about the opportunities and how we might address some of those issues. I'm very pleased we've got somebody called Mindy Fullerlove, who is a professor at the New School in New York, who talks a lot about urban renewal and the unintended consequences of urban renewal, particularly in the US. So we're going to have a look at that on the 13th of October. So if people are interested, it's an open invitation, and I really want it to be people other than people from the NHS, because it has to be the broadest possible conversation. Right, that's the advertising done. So thanks everybody for their time, and I hope it has been useful for you. And in particular, Manoj, thank you for your insights and fascinating conversation.
Well, thank you. I appreciate you asking me to join you, and I feel like you're the experts, and I'm only sharing my own experiences. I did put the link to the article if people were interested. It's freely available. You'll find a lot of other good resources in the Systems Thinker sort of compendium that are free to stimulate your thinking. So
that's fabulous. So thank you very much, and enjoy the rest of your working day.
Just getting started. Yes, you too. Have a good evening.
Thank you very much. Thanks, Manoj, and thanks everyone else.